now discuss a very important chapter in pediatrics, that is pediatric neurology. So starting with congenital anomalies of CNS and specifically the neural tube defects. So these neural tube defects are basically due to improper closure of the neural tube. Okay, so it is due to failure of proper closure of neural tubes, Okay, so these neural tube disorders have multifactorial inheritance. So a lot of factors come into play. Okay, they have multifactorial inheritance. Okay. What are the different examples, some examples of neural tube defects before going into discuss them? So some examples would include meningocele, meningomyelocele, okay, anencephaly, spina bifida occulta, iniencephaly, okay, encephalocele, so these are some of the examples of neural tube defects. Okay, the diagnosis of neural tube defects can be done even antenatally. So antenatally you can diagnose it by ultrasound. The large neural tube defects can be diagnosed by this, or you can do some biochemical markers during pregnancy. So you can look at maternal serum or amniotic fluid alpha fetoprotein levels or acetylcholinesterase levels to get a clue of its presence. Okay. And remember, neural tube defects are very, very common. In fact, it is the most common congenital neurologic abnormality in children. Okay. So neural tube defects are the most common congenital neurologic abnormality in children. Okay. And there is something that you can do to prevent neural tube defects. What can you do? So we can do folic acid supplementation in the pregnant ladies, not just in pregnant ladies. Actually, it is the folic acid should be started even before planning pregnancy. So prevention of neural tube defects. So for the prevention of neural tube defects, folic acid supplementation which should ideally be done in all women of childbearing age. Okay, all women of childbearing age, you do folic acid supplementation to prevent neural tube defects. So what is the dose of folic acid that is recommended? So it has been asked in the AIIMS exams also previously. So folic acid supplementation should be done for the prevention of neural tube defects. So what is the dose? So the dose is 400 microgram per day or 0.4 milligram per day. Okay, in all women of childbearing age. While the dose is 10 times of this in high risk women who have a previous history of, children with neural tube defects. So the dose is 10 times. So this dose will be 4000 microgram per day or 4 milligram per day in high risk women. And when should this folic acid be started, supplementation be started for it to become effective? So not when the pregnancy is diagnosed. It should ideally be started before conception. Okay, so even before pregnancy is planned. So at least 1 month before conception it should be started. Okay. So when should it be started? So it should ideally be started at least 1 month before conception. And it is to be continued at least for 12 weeks during the first trimester minimum. Okay. Now this folic acid, giving antenatal folic acid will will prevent neural tube defects in how much percentage of cases? So it decreases the risk, this supplementation of folic acid. That has been asked in a recent question once. So folic acid supplementation decreases the risk of neural tube defect. Decreases the risk of neural tube defect by around 70%. Okay, 70 to 72%. And even though there is no well-defined mechanism of inheritance of neural tube defect, we said it is multifactorial inheritance. But if there is a history of that a lady has already got one child affected with neural tube defect, then there is a risk of recurrence in the other child. In the next child, there is a risk of 3 to 4%. Okay, so risk of recurrence with one affected child, it may be asked. So risk of recurrence with one affected child with NTD is 3 to 4%, while if 2 previous children are affected, this risk becomes 10%. Okay. Okay. So hydrocephalus. What do you mean by hydrocephalus? So hydrocephalus is a condition where you get enlargement of the ventricles inside the brain, which can be either due to increased production or impaired drainage of CSF. Okay. So hydrocephalus is a condition where you get enlargement of ventricles inside the brain either due to increased production or impaired drainage of CSF. Okay. There are two main types of hydrocephalus. One is communicating hydrocephalus, where all the ventricles are uniformly enlarged. Another is non-communicating hydrocephalus, where some of the ventricles are enlarged, others are not. So this non-communicating hydrocephalus is also called obstructive hydrocephalus. Okay. So the two types are communicating hydrocephalus, where all the ventricles are uniformly enlarged, and non-communicating or obstructive hydrocephalus. Okay. So some important causes of each of them we need to know. So first, let us see some important causes of communicating hydrocephalus. So important causes of communicating hydrocephalus include choroid plexus papilloma. So where is CSF produced from? Choroid plexus. So if you have a tumor of choroid plexus, then there will be excess production of CSF. Okay. So choroid plexus papilloma is one. Then communicating hydrocephalus you can also get in achondroplasia. Okay. You can also get it in meningeal malignancy or metastasis. And it can be post-hemorrhagic as well, following a subarachnoid hemorrhage. Okay. So you can remember these causes of communicating hydrocephalus by a mnemonic CAMP. So C for choroid plexus papilloma, A for achondroplasia, M for meningeal malignancy or metastasis, and P for post-hemorrhagic. So these are some important causes of communicating hydrocephalus. Now moving on to some important causes of non-communicating hydrocephalus. So important causes of non-communicating hydrocephalus would include mass lesions. So if there is an intracranial mass lesion, or it is also called intracranial space occupying lesion, okay, ICSOL, intracranial space occupying lesion, which is compressing on the ventricular system, you can get obstructive hydrocephalus. Similarly, you can get it if you have a large abscess which is compressing on the ventricular system. You can get it in a condition called aqueductal stenosis. So what is aqueduct of Sylvius? So it is a connection between the third ventricle and the fourth ventricle. So if there is a narrowing, a stenosis of the aqueduct of Sylvius, what will happen? The lateral ventricles and the third ventricle will enlarge, but the fourth ventricle will not. Okay. So you get a non-communicating or obstructive hydrocephalus in that case, right? So mass lesion, abscess, aqueductal stenosis, then some other malformations like Arnold-Chiari malformation. Okay. Dandy-Walker malformation. A large hematoma which is compressing on the ventricular system. Some CNS infections like congenital toxoplasmosis, okay, toxoplasmosis, CNS mumps. NCC or neurocysticercosis. Tubercular meningitis can also sometimes give rise to non-communicating hydrocephalus. Then another malformation, an important one, that is called vein of Galen malformation. Okay. So vein of Galen malformation we will suspect in any condition where you get a, this has come as a question many times. So vein of Galen malformation we will suspect when you get a case scenario where you are getting, say, a neonate who is presenting with features of heart failure, bounding pulses are there, okay, heart failure, high output heart failure. So heart failure with bounding pulses are there. Large bulging anterior fontanelle is there. Large bulging anterior fontanelle. Okay. And if you put your stethoscope on the anterior fontanelle, you will hear a murmur like sound that is called cranial bruit. Okay. So cranial bruit on auscultation over AF. So that is a typical case scenario where your diagnosis will be vein of Galen malformation. Okay. So these are some of the important causes of non-communicating or obstructive hydrocephalus which we can remember by a mnemonic MAD HIV. So the HIV is really MAD. So M for mass lesion, A for abscess, another A for aqueductal stenosis, a third A for Arnold-Chiari malformation, D for Dandy-Walker malformation, H for hematoma, I for infections, and V for vein of Galen malformation. So these are some important causes of hydrocephalus in children. So we saw some important causes of communicating hydrocephalus and some important causes of non-communicating hydrocephalus. Okay. Now moving on to the treatment of hydrocephalus in children. So one is the medical management and another is the surgical management. Okay. So medical management would involve use of drugs like acetazolamide and glycerol, which can be used for long term, decreasing the raised intracranial tension. And acutely, you may have to use some drugs like mannitol or hypertonic saline. So, for acute condition, you might need 3% NaCl, that is hypertonic saline or mannitol. And for long standing problem or chronic problem, you may need to give oral drugs like acetazolamide or glycerol. Surgical treatment. So it has come as a question previously in one of the exams. So surgical treatment, what is the surgery of choice or what is the shunt surgery of choice in a child with hydrocephalus? Then the answer is VP shunt or ventriculoperitoneal shunt. Okay. So it is VP shunt or ventriculoperitoneal shunt. So where you make a connection between the ventricles of the brain and the peritoneal cavity. So the excess CSF is drained into the peritoneal cavity and the child is relieved of the symptoms. Okay. So it is called a ventriculoperitoneal shunt or VP shunt is the shunt surgery of choice. Apart from that, if there is aqueductal stenosis, you can do a lesser invasive procedure which is done nowadays. So for aqueductal stenosis, we can do something known as endoscopic third ventriculostomy can be done. Okay.